Hello everyone. Today we will talk about the oxygen therapy escalation care protocol. This protocol serves as a valuable example guide for healthcare professionals managing patients requiring oxygen therapy. I created this protocol in response to the Quebec Order of Respiratory Therapists and their document titled, Request for Enhancement of the Diploma Opening the Door to the Respiratory Therapy License. In the first section of their document, they write, and I quote, "The gap between expected skills and knowledge mainly concerns the ability to exercise clinical judgment. The improvement will aim to refine clinical judgment. Clinical reasoning is not a competency nor an element of competency nor even a criterion of performance in itself. In response to this question about clinical judgment, I suggest to the OPIQ, Quebec Order of Respiratory Therapy, to integrate a standard protocol and algorithm. The current documents available on the OPIQ website are outdated and do not necessarily provide an overview or suggest what the clinician should do in certain scenarios. Why algorithms? They improve the efficiency of tasks. They enable quick and effective decision-making as information is processed rapidly. They streamline cognitive load by handling large amounts of data, executing routine tasks, allowing clinicians to focus on more complex and nuanced aspects. They provide real-time feedback during the simulation of various scenarios, contributing to a better understanding of medical actions. To illustrate this, let me present an example of a protocol that OPIQ could suggest. I created this protocol because many students on clinical placement or in practice always question the proper management of oxygen. This protocol, inspired by the British Thoracic Society, is exclusively used for hypoxemic respiratory failure. It also incorporates the escalation of basic oxygen care proposed by the Toronto Notes. It should not be confused with the treatment of hypercapnic respiratory failure. Here is the protocol. As you can see, the protocol is clearly defined with specific instructions, making it easy to implement. It provides precise criteria for assessing the patient's condition, aiding in informed decision-making. Furthermore, it covers a variety of scenarios, including unstable patients and those in resuscitation. For instance, it guides the clinician on both stable and unstable patients requiring oxygen. However, like any tool, this protocol has its limitations. For instance, it may be complex to follow, especially in emergency situations where time is crucial. Therefore, I suggest practicing it in simulation before applying it to real patients. Also, the protocol is indicated for managing hypoxemic respiratory failure and not hypercapnic. Like any algorithm, this one includes details in the form of remarks and notes specifying certain sections. For example, it emphasizes the importance of using a CO2 sensor. Let's look at an example with a fictitious patient. Mr. Hong Lo, 65 years old, has been admitted to the hospital for respiratory difficulties. He is conscious but struggling to breathe. According to our protocol, the first step is to assess Mr. Hong Lo's condition using the protocol criteria, including respiratory rate, oxygen saturation, and other clinical signs, to determine the patient's status. The saturation shows 90% in ambient air, and the patient is working hard to breathe. As the patient has dyspnea but is not yet in a critical condition, following the arrows also determines that he may be at risk of developing hypercapnic respiratory failure. At this point, it is important to have a CO2 sensor in place. Following the algorithm, it is determined that there is no hypercapnia present and there is no deterioration in the level of consciousness. Therefore, for now, a nasal cannula set between 2 to 4 liters per minute is the appropriate device for this patient. By performing this intervention, we are inclined to monitor for an improvement in the patient's condition. Suppose the condition does not improve. Following the arrows, the algorithm starts again from the evaluation of respiratory failure. Following the arrows, our patient is having difficulty sustaining respiratory effort and his level of consciousness is decreasing. If unsure how to assess the level of consciousness, we can rely on the note, which indicates an alteration of consciousness indicates a Glasgow score lower than 15 or deterioration according to the AVPU scale, alert, verbal, pain, or unconsciousness. Oxygen saturation also decreases below 88%. At this point, at our discretion, we may consider whether the patient meets the criteria for non-invasive positive pressure ventilation or if high-flow oxygen therapy should be initiated. Some indications for non-invasive positive pressure ventilation include: by indication, an exacerbation of COPD, hypoxemic respiratory failure, cardiogenic pulmonary edema, post-extubation weaning, patients declared do not intubate. By symptoms, respiratory rate higher than 30 breaths per minute, use of accessory muscles, thoracoabdominal swinging, according to arterial, venous, or capillary blood gases if available, ACO2 pressure greater than 45 millimeters of mercury, a pH lower than 7.35, an oxygen pressure to inspired oxygen fraction ratio lower than 200. Regardless of the chosen and installed device, monitoring and observing the patient's clinical condition are resumed. Referring to the remark, it indicates the criteria for the beginning of oxygen weaning. That is, improvement or, if the patient is stable, de-escalation of care can be initiated from the last device. De-escalation can be initiated when oxygen saturation is at 100% and remains stable for a certain time and consciousness improves as well as respiratory effort decreases. Hemodynamic status remains stable. Arterial gases, if available, show a favorable increase in oxygen pressure following the administration of additional oxygen. The same scenario can be applied to unstable patients by following the respective arrows. As you can see, this protocol has its strengths. The protocol is clearly defined with specific instructions, making it easy to implement. It provides precise criteria for assessing the patient's condition, aiding in informed decision-making. It covers a variety of scenarios, including unstable patients and those in resuscitation. It guides healthcare personnel through the decision-making process, which can help ensure consistent and effective patient care. Please note that this information is based on the interpretation of documents and should not replace professional medical advice. In case of a medical emergency, please immediately contact the appropriate medical authority. If you are interested in this protocol, I invite you to go to the address on the patreon.com website and visit my page to download this protocol by subscribing and showing your support for the creation of my content. I also recommend subscribing, liking, and sharing this content.